lecture today is about pharynx and spaces. So, starting the outline, we will have the pharynx, its parts, and pharyngeal wall layers. Then we will have a brief talk about neck fascia because they are relevant for the anatomy of neck spaces, then pterygopalatine fossa. Then we'll have some details about some supra and infrahyoid neck spaces. And finally, radiology of the pharynx. So, pharynx is that muscular tube extending from skull base till the level of cricoid cartilage, which is at C6 level, where it becomes continuous with the esophagus. It forms a common pathway for respiratory and digestive tracts and consists of three parts. Nasopharynx behind the nasal cavity and extends from the posterior choana till the free border of soft palate. Oropharynx behind oral cavity and extend from that point till the tip of epiglottis or level of hyoid bone. And hypopharynx or laryngopharynx, which extend from that level till the cricoid cartilage. Regarding the nasopharynx, it is bounded above by clivus, which is formed by the sphenoid bone anteriorly and the occiput posteriorly. From behind, it is lying upon atlas and axis, and below it has the soft palate and open posteriorly into oropharynx. On its lateral wall, it has the opening of Eustachian tube, and behind which there is a ridge formed by the cartilage of the tube called torus tuberous. And behind this, there is a recess called lateral pharyngeal recess or fossa of Rosenmüller, which is the most common site of origin of nasopharyngeal carcinoma. It is lined by lymphoid tissue, which is more prominent superiorly, forming adenoid tonsils. Also, there is lymphoid tissue around the opening of Eustachian tube, forming tubal tonsils. Regarding the oropharynx, it is bounded behind by the posterior pharyngeal wall. Laterally, it has anterior and posterior tonsillar pillars, and between them there is palatine tonsils. Anteriorly, there is posterior part or the base of the tongue, demarcated by circumvallate papillae, and within it there is lingual tonsils. This axial CT showing the palatine tonsils. Regarding hypopharynx, it will mold around the proximal part of the larynx, forming two piriform fossae, which will help to divert food laterally away from the larynx into the esophagus. This part is epiglottis, and in front there is a recess on either side formed by central glossoepiglottic fold called valleculae. Some filling of valleculae and piriform fossa is a normal finding, but overfilling may lead to aspiration. Regarding pharyngeal wall layers, it consists of three parts. Innermost is the mucosa, which is continuous with that of oral and nasal cavity. That is to say, it is a columnar epithelium at the nasopharynx and stratified squamous epithelium at the oro and hypopharynx. The submucous layer is pharyngobasilar fascia, which is thick fibrous cord, give pharynx its shape, attached superiorly to the skull base, and pierced by Eustachian tube, and at a lower level, it is pierced by the levator villi palatine muscle, which will then insert into posterior part of soft palate. The outermost layer is the muscular layer. Regarding the muscular layer, it consists of outer circular muscle and inner longitudinal. The outer consists of superior, middle, and inferior constrictors. The inner consists of stylo, palato, and salpingopharyngeus. All of them are supplied by vagus nerve, except the stylopharyngeus, which is supplied by glossopharyngeal nerve. So, the constrictors will attach posteriorly to a median raphe, extending from skull base anterior to the foramen magnum, and inferiorly continuous with the esophagus. The superior constrictor will attach anteriorly to pterygoid humulus, which is inferior extension from medial pterygoid, And from that point, it will join directly to the inner surface of mandible. Regarding longitudinal muscles, stylopharyngeus will attach to styloid process and the palatopharyngeus from the soft palate, and salpingopharyngeus from the cartilage of the eustachian tube, and will merge with the fibers of palatopharyngeus. Then palatopharyngeus and stylopharyngeus will insert into thyroid cartilage, and by contraction, they will elevate the pharynx and larynx upward during swallowing. Also, the palatal muscles will help elevate the soft palate during swallowing. And with a ridge formed by contraction of superior constrictor called passivant ridge will help prevent food from reflexing into the nasopharynx. Middle constrictor will attach anteriorly to the lower part of stylohyoid ligament and to the hyoid bone. And regarding the inferior constrictor, it consists of two parts: oblique fibers attached to the thyroid cartilage forming thyropharyngeus muscle, and horizontal fibers attached to the cricoid cartilage forming cricopharyngeus. Between them posteriorly, there is a Killian dehiscent, which is a weak spot through which pharyngeal pouch may arise. Regarding cervical fascia, they consist of superficial fascia, which contains subcutaneous fat and the platysma muscle. The deep fascia consists of three layers: the superficial or deep investing fascia, the middle or pretracheal fascia, and the deep or prevertebral fascia. All of them will condense around the carotid vessels and form carotid sheath, which will define the carotid space. Regarding superficial layer of deep cervical fascia, it will encircle the entire neck and attach posteriorly to the nuchal ligaments and envelope trapezius and sternocleidomastoid muscles, and will form the roof for posterior triangle or posterior cervical space. It will continue upward and will envelope the masticatory space and carotid space. Regarding the middle layer, it will encircle the viscera, including thyroid, parathyroid, trachea, and larynx above, and esophagus. It will also contain the carotid-laryngeal nerve. In other words, it will define visceral space. The posterior wall of pretracheal fascia is called buccopharyngeal fascia, which will continue upward, and from its name, it will in part envelope buccinator muscle and the other part the pharyngeal muscles, forming outer to the constrictor muscles, which is a loose layer to allow movement of the pharynx. Behind the buccopharyngeal fascia, there is retropharyngeal space. Regarding the deep layer, it will define the perivertebral space and has anterior subdivision called alar fascia. This alar fascia will divide retropharyngeal space into anterior true and posterior dangerous space. So why it is called dangerous space? So this is buccopharyngeal fascia, which will surround constrictor muscles, and behind which alar fascia, which will divide retropharyngeal space into anterior true retropharyngeal space and posterior dangerous space. So there is some sort of fusion between alar fascia and buccopharyngeal fascia between C6 and T6. So prevents spread of infection from retropharyngeal space to the mediastinum. But this is not the case for dangerous space, so infection may spread easily from that space downward. هاي طالعة سيمكم. Okay, so regarding pterygopalatine fossa, so looking at this skull, okay. So the pterygopalatine fossa is just a depression posterior to the maxilla and binded posteriorly by the pterygoid process of sphenoid and medially has the palatine bone. Here is the palatine bone, which will form the posterior part of hard palate. Laterally, it is connected to the infratemporal fossa via the trigomaxillary fissure. Regarding infratemporal fossa, which is right here, it is connected to the middle cranial fossa via foramen ovale and foramen spinosum, and to the temporal fossa via the gap between zygomatic arch and the side of the skull. Both of them are connected anteriorly to the orbit via the inferior orbital fissure. So looking from forward, so this is the orbit, and this is the inferior orbital fissure. Looking downward, it is connected posteriorly to the pterygopalatine fossa and laterally to the infratemporal fossa. Regarding the connections of pterygopalatine fossa, we said the anterior connection to the orbit and the lateral connection to the infratemporal fossa. It has the sphenopalatine foramen, which will connect it to the nasal cavity. Inferiorly, it has greater and lesser palatine canals and foramen, which will connect it to the hard palate. So here is the greater and lesser palatine foramina. And it has the sphenoid bone, so take it. We said that pterygopalatine fossa is bounded anteriorly by maxilla and posteriorly by pterygoid process, so it will be here. So regarding posterior connections from superior to inferior, it will have foramen rotundum, pterygoid canal, and medially, posterior medially, it will have palatovaginal canal or pharyngeal canal, which will connect it to the nasopharynx. So foramen rotundum will connect it to the middle cranial fossa and will transmit the maxillary branch of trigeminal nerve. Regarding the pterygoid canal, it will be right there between the body and the greater wing of sphenoid and will open near the foramen lacerum. So it will carry parasympathetic nerves from greater petrosal nerve, which is a branch of facial nerve, and sympathetic nerves from around the internal carotid artery, forming the median nerve or nerve of pterygoid canal. أرجع حسب الباوربوينت.
رجع بنجهز.
تمام. So regarding the content, it will contain the pterygopalatine ganglion, which is the largest parasympathetic ganglion. The largest one is the pterygopalatine. Others are otic ganglion, submandibular ganglion, and ciliary ganglion. So we say that nerve, median nerve, and the maxillary nerve will give ganglionic branches. Then the maxillary nerve will divide into zygomatic and infratemporal, which will go through an infraorbital fissure. The infraorbital nerve will divide into anterior superior and middle superior alveolar nerves. The maxillary nerve will also give posterior superior alveolar nerves. All of them will supply the maxilla and upper teeth. The pterygopalatine ganglion will also give nasal branches, pharyngeal branch through pharyngeal canal, palatine branches through greater and lesser palatine foramina, and also orbital branches. Other contents within the fossa are the maxillary artery, which will enter the fossa via the pterygomaxillary fissure and will divide into descending palatine artery, pharyngeal artery, artery of the pterygoid canal. It will also give posterior superior alveolar artery and infraorbital artery, which will again give anterior and middle superior alveolar arteries. Then it will give the terminal branch with the sphenopalatine artery, which will go to the nasal cavity. So this is XCLCT image bone endo showing the pterygopalatine fossa connected posteriorly to the pterygoid canal to the foramen lacerum, laterally via the pterygomaxillary fissure to the infratemporal fossa, and anteriorly to the orbit via the inferior orbital fissure. For those wondering how to differentiate between superior and inferior orbital fissure on XCLCT image, if you see a bony defect that will open into pterygomaxillary fossa or the infratemporal fossa, it is the inferior fissure. But if you see a bony defect that will open into the middle cranial fossa, that is to say it will have a posterior boundary by the temporal lobe of the brain, then that is the superior orbital fissure. Also, the superior orbital fissure will be at higher level, so you won't see clivus, you won't see the mustard air cells, you won't see the head of the mandible or mandibular fossa, you won't see parts of maxillary sinus. So again, this is medial and lateral pterygoid, maxillary antrum or sinus, and in between them, palatine bone. So this is pterygopalatine fossa, and this is the greater and lesser palatine canals. This is greater palatine canal within palatine bone opening into hard palate. This is pterygopalatine fossa connecting posteriorly to the foramen lacerum by median canal, medially to the nasal cavity via sphenopalatine canal. Laterally via pterygomaxillary fissure to the infratemporal fossa, and superiorly to the orbit via inferior orbital fissure. Again, this is middle cranial fossa, so this is foramen rotundum. This is the inferior orbital fissure connecting it to the orbit, and foramen rotundum to the middle cranial fossa. Okay, keep focus. We'll go through some details of neck spaces. Okay, regarding the suprahyoid neck spaces, they consist of masticator space, carotid space, parapharyngeal space, perivertebral space, retropharyngeal space, and parotid space. Regarding infrahyoid neck spaces, they consist of visceral space, carotid space, posterior cervical space, anterior retropharyngeal space, and perivertebral space. So carotid, retropharyngeal, and perivertebral space are both supra and infrahyoid. So the parapharyngeal space is just a slit-like space lateral to the naso and oropharynx, and it is shaped like a vertical pyramid base at the skull base and the apex at the greater corner of hyoid bone. It is a deep space around which most other neck spaces are arranged. So medially it has nasopharynx or pharyngeal mucosal space. Posteriorly it has retropharyngeal space and the carotid space, being separated from the carotid space by the styloid process and its muscles. Anterolaterally it has masticator space. Laterally it has parotid space. Regarding the content, it contains mainly fat, so it is hyperintense on both T1 and T2 image. It also contains a branch from the maxillary ascending pharyngeal to the pterygoid venous plexus and nerves. Salivary tissue may also be present within the space, which may be either deep portion from the deep loop of the gland or minor or clumped salivary tissue. Infratemporal space, we have mentioned it earlier. As we said, it is connected to the temporal fossa via the space between the zygomatic arch and the side of the skull, connected to the pterygopalatine fossa via pterygomaxillary fissure. Medial boundary, it is the lateral pterygod plate. Again, greater ring of sphenoid lateral pterygod plate, floor by medial pterygod muscle, and lateral boundary, ramus of mandible and chronoid process. So it will contain mandibular nerve and its branches, including lingual. For the tympanic nerve, which is a branch of facial nerve, which will carry sensations from anterior two-thirds of the tongue. Superior alveolar branch of maxillary nerve, and otic ganglion, which is another parasympathetic ganglion related to the glossopharyngeal nerve and will supply the parotid gland. Blood vessels, maxillary artery, and its branches under the pterygod venous plexus. Muscles, medial lateral pterygod, and tendon of temporalis. Masticator space actually overlaps with the infratemporal space, so the same content, but in addition, it will contain the ramus and body of mandible and masseter muscle. So it will have the lateral pterygod, which is superior because it will attach to the head and neck of mandible. The medial pterygod will attach to the inner surface of mandible and temporalis muscle. This is mandibular nerve emerging from foramen ovary. Actually, these spaces may serve as a means of spreading infections and tumors around the nerves into cranial fossa. This is axial sections, medial pterygod, lateral pterygod muscle, temporalis muscle, and masseter. In front of them, the retromaxillary fat pad, which will continue below the buccal space. So the masticator space is enveloped by superficial layer of deep cervical fascia, which will also envelop parotid gland. Posteriorly, it has parotid space, medially and posteriorly parapharyngeal space, and the carotid space. Regarding carotid space, it is the most lateral of suprahyoid neck spaces. It will contain the parotid gland and the facial nerve after emerging from stegmostyle foramen. It also contains retromandibular vein, which is larger and lateral, and the external carotid artery, which is medial and smaller. It also contains intraparotid sphincters. The carotid space, which is right here, is enveloped by the carotid sheath and extends from skull base to the aortic arch. Regarding its contents, the common carotid inferiorly and the internal carotid superiorly, which is medial and smaller, internal jugular vein, which is larger and lateral, and the same nerves that emerge with the internal jugular and the jugular foramen posterior cranial fossa, which are the glossopharyngeal, which will be anterior to the vessels, the vagus, which will be posterior to the vessels, and accessory nerve. It also contains hypoglossal nerve and sympathetic nerves medial to the vessel and lateral to the retropharyngeal space. It also contains level 2, 3, and 4 deep cervical lymph nodes. Regarding the perivertebral space, it is invested by the deep layer of deep cervical fascia, which will send a slip to the transverse process of vertebra, dividing the space into anterior prevertebral space and posterior paraspinal space. So it will contain prevertebral muscles, which are, for example, longus pulla muscle, phrenic nerve anterior to anterior scalene muscle, roots of brachial plexus anterior to the middle scalene muscle, and posterior scalene muscles, paraspinal muscles, vertebrae, and disc. It also contains vertebral artery within transverse foramina. regarding the retropharyngeal space, it is just a space behind the pharynx, we said at the midline, divided by alar fascia into anterior through and posterior danger space, contain mainly fat and retropharyngeal lymph nodes, which will drain pharynx, nose, and middle ear. Regarding the posterior cervical space, it is right here, bounded anteriorly by the sternocleidomastoid and carotid space, roof formed by the superficial layer of deep cervical fascia, floor by the deep layer of the deep cervical fascia, posteriorly bounded by the trapezius. So the content, we can imagine that the brachial plexus, after emerging from the perivertebral space, will enter that space. It also contains the spinal part of accessory nerve, fat, and the posterolateral part of level 2, 3, and 4 lymph nodes. It also contains level 5 lymph nodes. So this is posterior cervical space, lateral and behind to the perivertebral space, having sternocleidomastoid anteriorly and trapezius posteriorly. Regarding plain film of the pharynx, so lateral view will demonstrate the soft tissue outline of the pharynx. For example, the posterior pharyngeal wall will form a soft tissue shadow in front of cervical vertebrae, which thins down until C4 level, where it measures 3 mm. Downward, it is thicker, but should not exceed the AP diameter of corresponding vertebra. In children, it is thicker to having lymphoid tissue. So at C4 level, it is 5 mm, and at C6 level, it is 12 mm. We can see also the soft palate, posterior third of the tongue, unerupted permanent tooth, body of hyoid bone, valleculae, epiglottis, at epiglottic fold. There must be a retinoid cartilage and corniculate cartilage. That radiolus anticipate is the ventricle, laryngeal ventricle, above which is the false vocal cord, below is the true vocal cord. And superiorly, you can see adenoid tonsils, which in pediatric age group tend to swell down, and all together with tubal tonsils. These are adenoid tubal tonsils at the lateral wall of nasopharynx, palatine tonsils at the lateral wall of oropharynx, and lingual tonsils at the base of the tongue. They form a continuous ring of lymphoid tissue. So this continuous ring is called Waldeyer rings, which is formed by pharyngeal tonsils, which are adenoids, tubal tonsils, palatine tonsils, and lingual tonsils. I think that was all. Okay, I think it is a quiz time.
اكو احد عنده سؤال قبل ما نروح للكويز؟ اذا نختار دعاء.
نعم استاذ.
أعرف شوية.
تطلع له.
اي تمام.
نمبر 1 frontal sinus.
فرونتال حسنى. نمبر 2 حسنى نعمت. داليا.
نعم inferior turbinates.
العفو دكتور، منو صحته؟
منو حسنى؟
توربينات دكتور، توربينات.
داليا نمبر 3.
Sphenoid sinus.
نمبر 4. حوراء. أسماء معين.
نعم
Number
دكتور
4
ماذا
nasopharynx.
العفو، حوراء محسن، حوراء حسين.
منو
لا أنا
صارت
دكتور حوراء
تداخل؟ حوراء نمبر 4 شنو قلتي بابا؟
حوراء محسن.
نازوفارنكس.
نيزوفارينكس. اوكي. علي شبر نمبر 5.
نعم أستاذ. نمبر 5 adenoids.
اكسلنت ادينويد. عندنا نمبر 6. وين نمبر 6؟ ميس زهير.
anterior arch of atlas C1.
اوكي. ابراهيم محسن نمبر 7. بسيط
نعم
هذا.
هذا كلايفس.
لايبس. اوكي. هبه مهدي. هبه. هاجر نمبر 8.
دكتور adenoid process of the axis. adenoid process of the
او
axis.
الدنس.
الدنس.
اوكي. او الدنس يصحوا له. نور شاكر نمبر 9.
نعم أستاذ. heart palate.
شنو؟
heart palate. نعم أستاذ.
سوفت باليت.
هذا مو الهارت البوين مؤشر عليه دكتور؟
على البون هاي
نمبر.
الهارت مال المكسلة، فهذا الهارت بلد.
اوكي. اوكي. نور اخترناها طبعا. العفو. بتول محمد نمبر 10.
soft palate.
سوفت. اوكي. آسر نمبر 11.
نعم أستاذ. أوروفارينكس.
أوروفارينكس. وسن محمود نمبر 12.
فاليكولي.
بالكولي. 13. زهراء مؤيد.
Mylohyoid muscle.
13
Mylohyoid muscle.
هذا مشر على بون.
نعم، وباللون
لا،
الأحمر، باللون
لا،
الأحمر
لا.
14
إيه،
مأشر.
اوكي اي صحيح. مايلوهيويد مصر. رؤى جمال نمبر 14.
البادي اوف هايويد بون.
صحيح. ولاست 1 15 نختار مهند جواد.
نعم أستاذ هذا إبيجلوتس.
This is the epiglottis. اوكي عشتكم. استاذ محمد تفضل.
هذا ريفيو للصورة شرحتها عن المود كونكشنز مال تريجو بالاتاين فوسا.
نعم. بس يوسف نمبر 1.
أستاذ إثمويد إرساينوس هذا إرس. يلا عفوا.
إثمويد إرساينوس. زين. ندى جابر.
العفو أستاذ، هاي ماكسيلاري ساينس نمبر 2.
نمبر 2 ماكسيلاري ساينس. زين. ضرغام عبد الكريم.
نعم أستاذ.
نمبر 3.
نمبر 3 أستاذ هاي الزايكوماتيك أرش.
زايكوماتيك أرش. زين. سالي كاظم.
العفو أستاذ. this is inferior orbital fissure. inferior orbital fissure.
نعم. زين. زينب سعيد نمبر 5.
نمبر 5 تريجو بالاتاين فوسا.
ترجع بالاتاين فوسا. زين. رؤى جمال.
الفيديان كانال نمبر 6.
فيديان كلام. زين. رؤى جبار.
نمبر 7 فورامين اوفالي.
فورامين اوفالي. حوراء حسين. Number 8.
foramen spinosum.
foramen spinosum. حسن حيدر.
نعم أستاذ. Pterygo maxillary fissure.
Pterygo maxillary fissure. زين. بتول محمد. Number 9.
كليفس.
شنو؟
Number 10. Number 10.
كليفس.
Number 9 قبلها أستاذ رعد.
قالت تريجو ماكسيلاري فيشر.
نعم. Number 10.
كليفس.
اوكي.
خلصت له عندك بعد شيء.
هاي عم بعد كم شغلات. We bothered about the quizzes, real life exams be like, and identify listener. Okay, regarding the reference, most of the information of this lecture are from Wikipedia and to a little bit from Anatomy for Diagnostic Imaging by Ryan. So if you need more information, please refer to these two. And that was all for today. Grateful for your attention and see you later.
شكرا دكتورة حسناء، عاشت ايدك.